Remind us that Ottawa is built on unceded Algonquin-Anishinaabe territory. The peoples of the Algonquin-Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And so now I'm delighted to present our speakers for this morning. We're very fortunate to have a resident presentation, group of resident presentation. And so our presenters for this morning, we have two PGY4 residents, Dr. Abdullah Al-Harbi and Dr. Justin Desrochers, and a PGY3 resident, Dr. Amina Alalou. So Abdullah and Justin are fourth-year pediatric residents at CHEO, and these are their words, are passionate about their clinical work, various ongoing research activities, as well as leadership and advocacy within the residency program. I think presenting at Grand Rounds today is testament to all of that. So, and as much as they love their time in Ottawa, they are both excited for the next stage of their career. For Justin, that's as a general pediatrician, and for Abdullah as a subspecialist in pediatric gastroenterology. So good luck to you both on that. And as co-lead of the advocacy curriculum, Amina is developing a social pediatric elective for trainees here in Ottawa. She also helped bring much of the beloved Francis Vulva Refuge to existence. She is currently on maternity leave, so thank you for taking time out, Amina, to join us for this presentation, and is excited to rejoin the program next year. She hopes to weave in her diverse set of experiences with a future career as a general pediatrician. They are going to present to us today on hyperbilirubinemia, a tune-up, revision of the new AAP Guidelines for Management of Hyperbilirubinemia in the newborn infants 35 or more weeks of gestation. So with that, I will turn it over to our presenters. I don't know who's going to lead off.
I'm going to start. Okay, so I'll just share my screen.
Okay.
So, morning, everyone. I just need to make it in slideshow mode. Can everyone see the screen?
Perfect.
Okay, all right. So everyone, thank you so much for joining us today. As Dr. Jabor kindly introduced, we're giving you a hyperbilirubinemia tune-up, revision of the new AAP guidelines just this past August, so right hot off the press. And this replaces the old guidelines from 2004. We don't have any disclosures, none of us. And in terms of the outline for this presentation, we'll try to present the guidelines via a case because we thought that's the best way to make sure we understand. We'll go over some definitions and physiology, as well as some epidemiology and risk factors briefly. And then I'll pass it on to Justin, who will review briefly the CPS guidelines, and then we'll get to the meat of the topic, which is when Abdullah will present the AAP guidelines. And then we'll compare the old and the new and leave some room for questions. So on a winter night like all others, a baby is born at COH. Introducing baby Billy, he's born term at 40 weeks to a G1 mother via spontaneous vaginal delivery. Vacuums did need to be used, so there's a phallohematoma. In terms of the antenatal record, mom is O positive, but the antibodies are unknown. And on assessment at 24 hours, the nurse noted that he looked jaundiced. Otherwise, he had been stable. And Mother Robin wants to go home. So let's talk about some definitions to make sure that we're all on the same page. When we talk about jaundice, we're talking really about the yellowish discoloration of the skin, secondary to high levels of bilirubin. It's classically described as progressing in a cephalocaudal order. Although it can be quite unreliable in terms of when somebody notices a baby's jaundice versus others, but typically when it's just the face that's jaundiced, you can expect a bilirubin level between 68 and 137 micromole per liter. And if it's the entire body that's jaundiced, typically the TSB or the total serum bilirubin is greater than 257 micromole per liter. Hyperbilirubinemia is the elevation of the serum bilirubin, and the threshold depends on multiple factors, which we'll get over. There's two kinds of hyperbilirubinemia, either an increase in the unconjugated, which is the waste product of the hemoglobin breakdown, which is where bilirubin comes from, Or when this breakdown is converted hepatically by the UGT enzymes, it forms conjugated bilirubin. It's the conjugated bilirubin that's water soluble and excreted via the bile. In terms of what we get in the lab, we get either an indirect or a direct. An indirect is unconjugated bilirubin, but the direct bilirubin is the unconjugated with some of the unconjugated. So the direct typically overestimates the conjugated bilirubin. And just as a FYI, there used to be a definition about the conjugated hyperbilirubinemia being greater than 20% of the total bilirubin. That's been dropped by the NASPGHAN 2017 guidelines. Severe hyperbilirubinemia is when TSB is greater than 340, and critical hyperbilirubinemia is when it's greater than 425. And why do we care so much about this? It's because at a certain point, typically greater than the critical hyperbilirubin level, we have bilirubin-induced neurological dysfunction. Typically, it occurs greater than 500, and it's very rare for it to occur less than the critical level of bilirubin of 425. What is acute bilirubin encephalopathy? Baby's initially quite sleepy but risable. You have mild to moderate hypotonia, but this will progress to either intermediate and then further to advanced ABE, which includes poor suck, shrill cry, retroculus, and opisthotonus with stimulation, as well as maybe fever. At this point, when a baby's in ABE, which none of us want to see, but if we do have that, it may be reversible. But when a baby is not appropriate, when an appropriate intervention is not taken in a timely manner, then this can progress to chronic bilirubin encephalopathy, which is a devastating diagnosis because it's irreversible. It includes chorioathetoid, cerebral palsy, upward gaze paresis, sensory neural hearing loss. And you might have heard of kernicterus. This is a pathological term of what we see when there's sections of the brain where we see the bilirubin deposit. So this is a picture of a baby with opisthotonus and hypertonia. This here is a score to let a clinician know whether they're in the initial or intermediate or advanced ABE. And over here is a pathological section of what the brain looks like in the deposits. There's a preference for the bilirubin accumulating in the basal ganglia. And the brainstem nuclei, which is what characterizes the symptoms that we see in chronic bilirubin encephalopathy. So how does this high level of bilirubin occur? Well, just briefly, it's a matter of the rate of bilirubin production versus the elimination rate. And newborns have several factors that contribute to the increase in hyperbilirubinemia, which to some extent, increased levels of bilirubin after birth can be protective, and we'll touch on that briefly later. But overall, the factors that are involved are the fact that newborns have elevated hematocrit levels of 50 to 60%. Their fetal hemoglobin has a shorter lifespan. And so both of these factors increase the hemolysis rate. In terms of the elimination rate, they initially typically have poor intake. They have a developing gut flora, which means that the conjugation, the excretion of the conjugated bilirubin can take time, which results in increased enterohepatic circulation and the immature liver as well. Neurotoxicity, which is what leads to bind and ABE, is when the bilirubin crosses the blood-brain barrier. What's important to note that it's actually not the bilirubin per se, but it's the free bilirubin, because most of bilirubin is bound by albumin, which is why one of the factors for knowing the risk factor for ABE is the albumin level. And the last term I wanted to go over is phototherapy. So phototherapy is basically helping the bilirubin, which is in the blood, change conformationally to an water-soluble isomer so that it may be excreted in the liver, in the kidney rather, sorry. So instead of just relying on the liver for excretion of the bilirubin, we're also helping the kidney excrete the bilirubin, which is why phototherapy is so effective. And now I'll pass it on to Justin.
Okay, so go ahead and move on, Amina. So we know that jaundice is super common. Up to 80% of term newborns develop jaundice. It's mostly physiologic, but there could be some other factors that come in and influence that. And like only 2% of babies get above our threshold for severe hyperbilirubinemia as defined by the CPS for 340 micromoles per liter. And talking about ABE and CBE, which are bilirubin encephalopathies, like they are quite rare. Like the most recent survey that we've had in Canada was in 2002 up to 2004. And we see that acute bilirubin encephalopathy has a 1 in 10,000 rate estimated per live births, and chronic bilirubin encephalopathy, thankfully more rare, at 1 in 50,000. And they think that oftentimes the cases that move forward into this realm are sometimes like type 1 Crigler-Najjar and like G6PD that was maybe underestimated and didn't come back from the community in time for help. So we see here that thankfully the incidence of extreme hyperbilirubinemia, this is a slide from up to date. It's defined like severe hyperbilirubinemia for them is greater than 428. So we see in the pre-phototherapy era in yellow, we had a much higher incidence rate. And once we came up with the orange bar, which is when we started saying if the kid looks jaundiced, we need to do a total serum bili, we started catching more of these kids and decreasing the rate. And moving forward into the universal screening era, we had an even further decrease in incidence of really severe hyperbilirubinemia, putting us in that realm for bind. And what are our risk factors for severe hyperbilirubinemia? Well, these are familiar to a lot of us from our CPS statement, like visible jaundice in the first 24 hours, visible jaundice before discharge, babies less than 38 weeks, previous sibling affected, visible bruising, cephalohematoma, male sex to a degree, maternal age to a degree, and otherwise we know that genetic ancestry can also play a role, and hydration and feeding are also factors that come into that balance that Amina mentioned of production versus breakdown, and trying to find an appropriate middle ground so that we don't need phototherapy. The AAP, let's come up with new risk factors, and I'll just let Amina click through them. So lower gestational age, jaundice in the first 24 hours. Ones that are different are highlighted in red. So they say a pre-discharge bilirubin concentration close to phototherapy threshold is a risk factor. Hemolysis from any cause. Phototherapy before discharge is also considered a risk factor. And again, similar one of the parent or sibling affected, a family history of an RBC disorder, exclusive breastfeeding, scalp hematoma, and interestingly, Down syndrome, and they add macrosomic infant of a diabetic mother. And we do see this quite a bit in NICU, and that these kids tend to have polycythemia, which is increases they have a higher RBC load. And it's also described that they just have less effective erythropoiesis and kind of like a bit of a higher rate of hemolysis, which contributes to that risk element. So back to Amina for a second here.
So back to baby Billy, we get a bit more history. So looking at the history, we see that we asked the mom, and she has no family history of previous children affected with an RBC disorder. And in terms of feeding, she's a first-time mom, so she's breastfeeding with a good latch of some colostrum present, but the milk is not in. So summarizing the risk factors for both the CPS and the AAP, they're both similar. So jaundice in the first 24 hours and scalp hematoma are the two main risk factors. We can't label it yet as suboptimal intake because it's with just the first day. Dr. Justin?
So this other concept that I had a hard time appreciating, I think, from the earlier days of my training is in the CPS statement. They do list risk factors for encephalopathy. And as we'll see from Abdullah in the new guidelines, they've redefined this as risk factors for neurotoxicity. And these are actually the risk factors that are present in our kind of phototherapy table that helps us kind of decide what are we low risk, or are we medium risk, or are we high risk, rather than the risk factors for severe hyperbilirubinemia. So again, generally, I put in red the isoimmune hemolytic disease and G6PD because they're not explicitly mentioned in the CPS statement, but they're in the graphs, as we'll see on the next slide. And otherwise, like the way to think about it is just any sign of distress, essentially, and prematurity is essentially a risk factor for encephalopathy plus hypoalbuminemia, as Amina went over. Again, anything that can maybe predispose you to having a higher free concentration of bilirubin that is unbound, including like acidosis, as is listed there, is just a consideration. And as we'll see on the next slide, the AAP keeps it very broad as well. But before we go there, I just wanted to highlight like the risk factors here are actually risk factors for encephalopathy in red and not risk factors for severe hyperbilirubinemia, which I know that sometimes I've had wrong in my head, because like the risk factors for severe hyperbilirubinemia are more to kind of stratify your decision making about when should I do my bili up front, and like how should I quantify this in the picture and the overall context of this kid's risk to continue having progressive hyperbilirubinemia, versus the encephalopathy risk factors, which are now neurotoxicity risk factors as defined by the AAP, help us decide on our phototherapy threshold. So the AAP has defined these as gestational age less than 38 weeks, and they risk stratify it beyond that, as Abdullah will tell us: hypoalbuminemia, isoimmune hemolytic disease, sepsis, and otherwise any form of significant clinical instability. Very broad term. They get into it in the statement saying like more acidic pH, certainly, but they can't commit to a specific pH because they just don't have enough evidence to say that there's a threshold where we're actually more worried about bind versus not. So they leave it to provider discretion to just say, based on your judgment of this patient's clinical stability, that would be a risk factor for neurotoxicity. Go ahead, Amina.
So back to baby Billy. So summarizing the case, there's no history, family history of hemolytic disease. There's a few drops of colostrum. There is ABO incompatibility, but the DAT is negative. And there's a cephalohematoma as well, but baby has been stable. And so the overall, in terms of the table of neurotoxicity and encephalopathy risk factors, there are none for both the CPS and the AAP. And so the impression is an exaggerated physiologic jaundice in a term newborn at 24 hours, and we need to get a TSB level. Back to Justin.
Okay, so we'll just quickly run through the current CPS guidelines. So go ahead, Amina. So nice, there's our guideline. So really what we all know and what we've all seen is that the CPS recommends is universal screening within the first 72 hours. We see that in general, this is always grouped with the infant, the newborn screening tests as well with the heel prick, so long as there are no other signs that are prompting us to do it earlier. So we do either we see transcutaneous bilirubin in other hospitals, less so here, and otherwise serum bilirubin. They're both equivalent as far as the recommendation for being used as a screening test. At least the only thing that the CPS statement says about the transcutaneous bili is just to know that there is a certain error margin that you should be aware of based on the machine. It's usually written out in the handbook. Generally, they quote it as 95% confidence interval between 36 and I think it was about 72. So just to keep in mind, when you have a transcutaneous bilirubin, if you're close to the phototherapy threshold, there is a confidence interval to think about. So whenever we have a bilirubin measurement, our next question is always, does it cross the phototherapy threshold? And then if so, we decide treat. And just at the same time afterwards, just review any risk factors for hemolysis afterwards, just to kind of maybe give us an idea of where this might be going. Because like we don't always have the full history for jaundice when the babies come to us. We still have to go ask the parents to clarify a couple questions, like any family history of G6PD, any family history of other kids affected, to quantify, are there any other risk factors for the severe hyperbilirubinemia? And otherwise, even if we have our risk stratification table that we know as well, which either once we take them off phototherapy, we plot them, or if they didn't cross the phototherapy threshold initially, we plot them, and then we decide based on the table that we'll see below. Let's just move on to Mina and we'll go through it. So for baby Billy, we see that with his Total serum bilirubin, that plots at 205s. We're above phototherapy threshold. He's low risk because he's a term baby greater than 38 weeks with no encephalopathy risk factors. So go on to the next slide. So technically, we don't need to use this up front because we're gonna use phototherapy we're gonna treat with phototherapy regardless. But if we would typically plot him afterwards once he's below phototherapy threshold in terms of disposition planning to see what risk zone do you fall in. And the reason why we use the risk zones is just because essentially for a baby, we know that for babies that were below the 40th percentile at the time of measurement, there's no really subsequent cases of total serum bilirubin really kind of then in general drifting back to above the 95th percentile, especially when that's the first initial measurement. And then for babies greater than the 75th percentile, we know that over 10% of them go on to develop severe hyperbilirubinemia. And for those greater than the 95th percentile, again, a greater than 10% of them also go on to develop severe hyperbilirubinemia. The interesting thing is overall is that this risk factor table has been completely scrapped in the new guidelines. So that'll be something to get used to because we're used to using that risk stratification table and those curves, I mean, and then supplementing it with this table that Amina just switched over to, where we use our gestational age and if we have a DAT to risk stratify our kiddos and to decide on further management. So for baby Billy, further testing or treatment will be required based on his upfront bilirubin. So even if we forgot to check the phototherapy threshold curves, we would still be told if we did the risk stratification and the table to, you need to assess if this kid needs to be treated, which is a useful backup mechanism that existed here. Now moving forward, just as a plug, the CPS says, when should we do a type and screen and DAT? Because it is included in their decision-making table. So if we have any moms that are Rh negative with kind of incomplete care, we don't know if they got their ROGAM or if there are any maternal autoantibodies, we should do it with the initial bilirubin assessment. Any mom with unknown blood type or antibody status, we should check it. And otherwise, any baby with mom is group O in a high intermediate zone or above, or requiring phototherapy, we should go ahead and do a type and screen and DAT. And you can go ahead, Amina. And this is just like a reminder that there is an exchange transfusion table buried into the CPS statement, and like we're well below the exchange transfusion threshold for baby Billy here, and really CPS kind of flags people to think about preparing for exchange transfusion up front when you have a total serum bilirubin between 375 and 425. But thankfully, as Amina told us, like ABE, which is acute bilirubin encephalopathy, is like essentially not described for total serum bilirubins less than 340 and very rare unless you're persistently above 425. So that's why the CPS statement has that number there. Okay, go ahead, Amina.
All right, so back to Abdullah now.
Okay, thank you, Justin. Can you make sure to mute here? Okay, thank you, Justin and Amina. Now we'll talk about the new chapter in treating hyperbilirubinemia based on the AAP new guidelines. Can we go? This is the article. It's like nearly 50 pages long article. So I'm going to summarize it in terms of things that have been affirmed, i.e. not changed. So we'll start just by listing them. So first, importance of checking for hemolytic isoimmune disease, i.e. knowing the mother's blood group and the antibody status, importance of adequate feeding and preventing hyperbilirubinemia. Number 3, always to think and consider hemolysis causes if there is jaundice visible in the first 24 hours. All newborns should get at least one bilirubin measurement pre-discharge. That was not highlighted in the 2004 guidelines, but it was highlighted in the CPS guidelines. Intensive phototherapy all the way, meaning high intensity phototherapy, although as per the AAP report in 2004, there's no consensus about phototherapy because there's like different companies, there's like variability between centers, but it's always intensive phototherapy. There's no room for like conventional or low intensity for this age group. Prolonged jaundice and when to investigate, and this is particular to infants, like whether exclusively breastfed or formula, and when to investigate and to think about cholestasis. Also, again, the importance of IVIG and pre-exchange transfusion and isoimmune hemolytic disease. And as mentioned, albumin is still is considered here as an option that can help you in decision making with regards to exchange transfusion by getting the bilirubin albumin ratio. And also, it's they reiterated the importance of doing emergency exchange transfusion whenever you have the bilirubin encephalopathy signs, as mentioned earlier, and the importance of parent indication with clear follow-up plans, and the importance of having written, documented number of like when was the last bilirubin level, at what age, and what was the weight, and clear follow-up plans to be handed to the parents. So here are the new things, like some of it like have changed or like are new things, and some of it have been highlighted. So first, they updated the nomenclature for like change the breastfeeding jaundice to suboptimal intake jaundice, and we are going to talk about each one of these. Number two, the hyperbilirubinemia and the neurotoxicity risk factors, as mentioned earlier. The higher thresholds for phototherapy and exchange transfusion, as we will see in the new graphs as well. Number four, TSB, total serum bilirubin check, post phototherapy initiation. Number five, CBC DAT G6PD check, and when you should be considering doing these investigations. Number six, phototherapy discontinuation and rebound hyperbilirubinemia. Number seven, a new thing, home-based phototherapy. Number eight, escalation of care concept, which is also a new thing. And number nine, a new post-discharge follow-up algorithm. So we'll start with number one. They updated the terminology about the breastfeeding jaundice. As we know, it peaks usually on day 3 to 5 after birth, and it's mainly due to excess weight loss and inadequate milk intake rather than the breastfeeding per se. That's why they changed it from breastfeeding to suboptimal intake hyperbilirubinemia. And this is also to say and reiterate the importance of having adequate feeding and to prevent hyperbilirubinemia. Next slide. And this is just a quick reminder. These are the factors, the neurotoxicity risk factors that you will be looking for, and to help you decide how to manage according to the phototherapy and exchange transfusion. So as we mentioned, gestational age less than 38, albumin less than 30, isoimmune hemolytic disease, sepsis, significant instability in the previous 24 hours. Next. So the new thresholds for phototherapy and exchange transfusion. So the AAP committee determined that the new evidence that bilirubin neurotoxicity does not occur until concentrations well above the 2004 exchange transfusion threshold, that justified raising the thresholds by a narrow range. And again, these thresholds, like those in 2004, are based on expert opinion rather than strong evidence. And just to weigh in the risk and the benefit versus the risk and harm, can we go to the next slide? They supplemented. As we know, phototherapy reduced the TSB levels, decreased the need for escalation of care, including exchange transfusion to prevent connect risk. Compared with the 2004 guidelines, over-treatment will be decreased by doing this raise of thresholds. The risk and harms, we usually don't think of phototherapy as like a harmful thing, but it is So other than there's separation of mother and baby, maternal anxiety, reduced breastfeeding, phototherapy can lead to oxidative stress and DNA damage. And there are 2 observational studies found a small increased risk of epilepsy in males treated with phototherapy. So the conclusion, the evidence is strong that phototherapy reduces the TSB concentration and the need for exchange transfusion. The evidence is weak regarding the specific phototherapy treatment threshold at which benefits exceed the harms. The guidelines thresholds were set to reduce overtreatment while not missing the potential benefit for reducing the risk for exchange transfusion or connectors. And this is the new graphs or the new thresholds, starting with the phototherapy curves. So as you can see here, the only question you will ask yourself at this point is, do you have any neurotoxicity risk factors? So the first graph for babies with no risk factors for neurotoxicity. And as you can see, gestational age here is separated from the risk factors compared to the previous guidelines where gestational age was included in decision making, whether it's like low risk, medium, or high. Now each gestational age has a different curve that you can follow. And this is the first graph when you don't have any neurotoxicity risk factors. When you go to the next slide, this is when you have 1 or more hyperbilirubinemia neurotoxicity risk factors. And the same that was done also moving forward to the exchange transfusion. The only question, do you have neurotoxicity risk factors or not? And moving to the next slide, when you have 1 or more neurotoxicity risk factors. And next slide. So this is like a good way to compare the numbers and the thresholds, the old and the new. So this is like comparing the low risk bilirubin thresholds from the previous guidelines with the new thresholds. As you can see, the solid line represent the old thresholds, while the dotted the lines represent the new thresholds. So you can see there's like the narrow range elevation. And as you can see, like moving forward to the medium risk, you can see like the dotted lines represent different gestational age, and the same you can see it in phototherapy and exchange transfusion as well. And moving forward to the higher risk thresholds as well. Next slide. Now talking about total serum bilirubin check post phototherapy initiation. Although it was not highlighted in the previous guidelines, but now the AAP recommends measuring the TSB within 12 hours after starting phototherapy, and they supplemented that the frequency or like the timing of the initial check, it depends on the age of the child, the presence of neurotoxicity risk factors, the TSB concentration itself, and the trajectory. The benefit behind this approach is to catch babies earlier if they are going to the escalation of care and exchange transfusion level, or if we can discontinue the phototherapy earlier. Next slide. This is like some of the things that have been highlighted, not a new thing, but now they are recommending getting CBC for all new babies on phototherapy to have a baseline and to rule out anemia. And when to check DAT, although it's like similar to the previous guidelines, but like whenever you have a mom who had a positive antibody screen, if she has a blood O group, regardless of the rhesus status, or if she has a rhesus negative status. And G6PD activity also, they reiterated the importance of considering G6PD. And whenever you have jaundice of unknown cause, or if you have a TSB increase despite intensive phototherapy, or if you have TSB increase suddenly, or if you have increase after initial decline, or if you have a baby reaching the escalation of care, which we will talk about. Next slide. Now we talk about the phototherapy discontinuation and rebound hyperbilirubinemia. So the to discontinue the phototherapy, you should have a TSB level at least like 34 micromoles per liter below the threshold. so that you can safely discontinue the phototherapy. Although they also supplemented with the option of having longer periods of phototherapy if you have risk factors for rebound hyperbilirubinemia, namely the gestational age of like less than 38, the age less than 48 hours at the start of phototherapy, or if you have a hemolytic disease. And rebound hyperbilirubinemia is defined as a TSP concentration that reaches the phototherapy threshold for the infant age within 72 to 96 hours after discontinuing phototherapy. So the repeat bilirubin measurement is based on the risk of rebound hyperbilirubinemia. And these are the risk factors, as we mentioned. So if you have a baby with risk factors for rebound hyperbilirubinemia, the TSP check post-discontinuation should happen earlier. So they are recommending that the first TSP check should be done 6 to 12 hours after phototherapy discontinuation. That is your first check. And the next check will be 24 hours after. For all other infants, like no risk factors for rebound hyperbilirubinemia, you should check like as we used to do, like the next check in 24 hours. Next slide. This is also a new concept. I'm not sure if it's have been done or applied in any other countries. Maybe this is something that we should look for in terms of minimizing the number of inpatient like with the high census that we have. So the AAP now they are recommending a home LED based phototherapy, but it has specific criteria. So first, you need to have a gestational age above 30, like 38 weeks or more, and the age is 48 hours or more. You have a clinically well baby with adequate feeding, no known hyperbilirubinemia, neurotoxicity risk factors, no previous phototherapy, and TSP concentration no more than 17 micromoles per liter above the phototherapy treatment threshold. And the device, the LED-based phototherapy device, will be available in the home without delay. And with that, you should be checking the TSP to be measured daily. The caveat behind the home phototherapy is first, it can decrease the anxiety and the need for readmission. For example, if you discharge the baby and then with the follow-up, they have this range of elevation, like 17 micromoles above the threshold. So it's an option to provide home LED-based phototherapy. But it depends, like first on the quality of the device and on the family reliability on like follow-up and when to seek medical attention. Next slide. So escalation of care is a new concept, and it refers to the intensive care that some infants with elevated or rapidly increasing bilirubin concentration need to prevent the need for exchange transfusion and possibly prevent connectors. And the escalation of care threshold defined as 34 micromoles per liter below the exchange transfusion threshold. And escalation of care is considered a medical emergency. And when we go to the next slide, it will tell you what does it entail exactly. So as you can see, the box in the middle. So whenever you are reaching that level of bilirubin, you should be sending stat labs, total and direct serum bilirubin, CBC, albumin, serum chemistries, type and screen, notify blood bank for potential need for exchange transfusion, measure the total serum bilirubin every 2 hours, intensive phototherapy with PO and IV hydration, and IVIG whenever applicable. So that's it basically regarding the escalation of care. Next slide. So now also the new recommendations include a new algorithm for post-discharge follow-up. The previous guidelines in 2004, they were assessing the risk for developing clinical significant hyperbilirubinemia based on nomograms using postnatal age, not gestational age, in hours, and bilirubin concentration coupled with the presence or absence of hyperbilirubinemia risk factors to determine the need for monitoring. they did not take gestational age neurotoxicity risk factors into account and was created from a study population that excluded DAT positive infants. And so the new guidelines, they are recommending using the difference between the bilirubin concentration and the phototherapy threshold at the time of measurement to determine the interval between discharge and follow-up and the need for subsequent total serum bilirubin or transcutaneous bilirubin measurements. And this approach incorporate both the gestational age and other hyperbilirubinemia neurotoxicity risk factors into the decision-making process. But this algorithm is only applicable for infants at least 12 hours of age and who have not received phototherapy before discharge. As you can see, moving to the next slide, this is the new algorithm. So basically, you start with measuring the bilirubin. If it's like below the threshold, and this is a well baby and you are considering discharge, then based on the difference between the threshold for treatment with phototherapy and the actual TSP level, and the original schedule, it's like in the black is the American units. So if the difference is like between 1.7 to 32.5 micromoles per liter, and the age is less than 24 hours, you should be delaying discharge, consider phototherapy, repeat TSP measurement in 4 to 8 hours. If this is a baby more than 24 hours of age, then you have multiple options. First, you can delay the discharge and consider phototherapy. You discharge home with home phototherapy, or discharge without phototherapy, but with close follow-up. And as you can see, as the difference is increasing, you have like longer periods of like checking, and also the supplemented, like it is up to the clinical judgment of the clinician.
So if we go now to Billy, just to make sure we solidify this this new guideline. Sorry. So baby Billy was 24 hours at the time of sampling. His TSP was 205. He's 40 weeks gestation, and there were no neurotoxicity risk factors. So if you go to Billy tool, it's already updated for the new guidelines. You put in this information, and then you will have recommendations based on the new guidelines. So based on the new guidelines, Billy is actually less than the phototherapy thresholds, which is different compared to the CPS guideline. They do mention, though, that if it was a TCB, because it's close to the phototherapy threshold, it would need to be repeated as a TSB. And in terms of what to do, then that goes to the discharge follow-up algorithm that Abdullah just went through. What you would need to do is either remeasure you need to remeasure in 4 to 24 hours. So in that case, you would either delay discharge, consider phototherapy, meaning that you would start phototherapy even before they reach the treatment threshold. The other option is to discharge home with home phototherapy if the criteria for home phototherapy are met. And the third option is to discharge without phototherapy, but just ask them to come back within 4 to 24 hours for a recheck. So basically, what we're seeing is in the CPS guidelines, Billy would be classified as low risk. His TSP would be above thresholds, and he would be started on phototherapy. In the new guidelines, he would not be, the TSP is below 3 treatment thresholds. And so there's different options that one may do. In terms of the going home aspect, he actually does not meet criteria for home phototherapy based on his age. And so that's not one of the options for him. So that's, you still have to understand to know the criteria for home phototherapy before just taking in the options on Billy tools. So with that, we wanted to leave some room for some questions. I know it's a lot of new information, and it's going to take us a while to get used to. So we're not exactly sure in terms of, you know, applying, implementing these new guidelines here at CHEO, and any other comments. We also made tables comparing the old and the new guidelines. I'll just in terms of the various sections. If anyone has specific questions about any specific part, we can also go to the table to see what's unclear. Okay.
All right, well, thank you, team, for a fantastic presentation. Thank you for going through that mammoth document from the AAP and distilling the key issues for us and putting it in a case format to actually bring it to life. So, you went through all the detail, you highlighted what was different, and you walked us through a case example, which was really helpful. I think your tables that you're showing here, Amina, are very helpful. I'm not sure where you're thinking about having these be accessible so that in the moment when someone's looking for that, they can actually find it. Maybe you can start with that. Tell us where people can find it when they're looking for it.
I mean, I'm sure the residents would love this, so we can always send it to in the resident group. But if there's any other way to share these tables, because it summarizes even like the little details in the AAP guidelines, I'll be happy to share.
Okay. All right. Well, any suggestions that anyone might have about that, please let us know. Okay. Maybe there's a suggestion or a question. Sarah Lawrence, over to you.
Hi there. The curves are present on Epic right now. The AAP curves are loaded into Epic, and so you just have to hit under. I mean, certainly I can see it on mine. I hope everybody else can, but it's under bilirubin, and the curves are all there. But it's the old AAP one. So I think these pediatric residents are keen on maybe seeing if we can change them and upgrade them to the new curves.
That would be great. Thank you, Sarah.
Are there any other questions?
It looks like Stuart Harmon has commented that it can be posted on CHEO.net as well. I know in Emerge we would put these in our clinical resources page. They can be in, I guess, various places, or it can be a search on CHEO.net as well. Thanks, Stuart, for that suggestion. Oh, and it looks like Toby is going to help you with a place to store the tables or share the tables. Toby, do you want to comment on that?
Just a wonderful job, and it's such a great topic. And so thank you, Justin, Amina, and Abdullah for the really awesome overview, very relevant to many of us. So I think we can meet after and then try and think about where the best idea would be to post these, but I think the tables are really helpful as we migrate to the new guidelines. So we can think about where the best place to share them are. And anybody on the call today who has ideas about where they would post within their group, let me know, and I can coordinate with the residents.
Thanks, Toby. And there's a comment also from Pradeep Merchant, who's head of neonates at the Civic. I'm asking for you to share the tables with the neonatology group, so going beyond the resident group at TOH, as they're at the front line for these babies. And also commented that it's an excellent presentation, so well done. There's Sarah Lawrence, you have your hand still up. I don't know if that's an old hand or a new hand. While you're okay, looks like it was an old hand. Okay, Greg Moore, over to you.
Yeah, thanks for the great presentation. And I think a comment also just came up. So instead of potentially putting the cart ahead of the horse, let's remember that CPS does review these and will also almost certainly be coming out with their own update. So we may want to use some caution in deciding to follow an American guideline before a Canadian guideline of major organization that does a great job in tailoring guidelines that have an American slant, for example, different litigation area, for example, there. And so there's different things that drive such guidelines. So we also may want to be aware of that and not necessarily jump to everything AAP.
Good advice there, Greg. Do you have any thoughts about when we might expect that? Is it currently being worked on, or is it in queue?
Good question. I'm not a part of the executive in CPS, so I don't know, but it certainly would be a pretty easy question to get an answer on.
Okay, great. Thank you. Next hand up is Justin Penner. Go ahead, Justin.
Thanks, guys, for such a really eye-opening presentation and keeping me up to date as well as everyone else. I guess my question sort of follows the same concept of, applying an American guideline to a yet updated Canadian guideline. And I think what we may need to consider from a specific Canadian context is those children that live in remote, isolated areas. And what I do worry a bit about liberalizing the guideline, although I'm all about less testing is those children who are going to be discharged early within kind of 24 to 48 hours back to their home communities where they won't have access to repeat testing or even perhaps repeat clinical examinations by someone who is astute in recognizing hyperbilirubinemia, particularly those, in our context in CHEO that will be discharged back to Baffin Island. That's just one of my kind of worries about these children then having to fly back to places, quite early in life that can just do a Billy, because that's quite difficult in those remote settings.
Okay, it looks like Abdullah and Justin are conferring about who's going to answer that one.
I can take this one. Yeah, so I agree. And based on the post-discharge follow-up, the recommendations are always they pair it with the clinical judgment. So knowing the family setting and where they live, and it's a good and valid point. And I think this will change your decision regarding discharging a patient if they live in the remote communities. Then you can delay the discharge, do another check, and after you have the AAP, the new recommendations, they also mentioned if you have 2 TSP checks below the threshold, then there's no need for another check after that. So that's it. Thank you.
There's just one more thing too, like thinking about rural and remote medicine and follow-up, and that we know that transcutaneous bilirubin isn't useful anymore once you start phototherapy. There's a bit of disagreement for when it becomes reliable again off phototherapy, but it might be an option just to use your transcutaneous bilirubin as a tool in a rural and remote nursing station, because it's just an easy tool to have for follow-up and to trend like a daily bilirubin for somebody just going to the nursing station every day. But at least it's described that you can consider using it again after 24, ideally more than 48 hours off phototherapy.
Thank you both. Okay, that's great. There's a question in the chat regarding whether you can comment on IVIG to reduce the need for exchange transfusion, although the current Cochrane meta-analysis does not support this. Anyone have any comment on that?
Yes, I can take that. So as I mentioned, so it is also mentioned again in the new guidelines that there is a role for IVIG, although the clear physiology or how it helps, it's unclear as they phrased, although there is some risk associated with the IVIG use, but it's again recommended in isoimmune hemolytic disease if you are reaching the escalation of care, the new concept we talked about, and preventing exchange transfusion. So it's still there, but there's no consensus for all the ABO or the hemolytic disease to be considered, because there's some benefit and risks with it.
Great, thank you, Abdullah. It's very helpful. Okay, we have a question from Dr. Merchant. Go ahead, Pradeep.
Thanks, thanks, Mona. Christina just actually addressed what I was going to say. The home-based phototherapy is a very, very important and maybe a timely initiative which we should be looking into it. I think Calgary already has a very well-established home-based phototherapy plans, and I think we should, from an Ontario point of view, we should be looking into it. And they have also looked into the TSB versus TCB and how can we actually use our local resources to avoid some of those admissions to the hospital or repeat admission to hospital. So this is a very timely conversation amongst all the primary caregivers, as well as the community outreach program in terms of how we can help out some of these low-risk babies with no neurotoxicity or hyperbilirubinemia risk factors attached to some of those babies. So it's a great conversation, a great topic to discuss, and we should move forward with that home-based program. Thanks, Mona.
Thank you, Pradeep. And it looks like there's comments that there's also a home-based phototherapy program in Manitoba as well as in Alberta. I don't know if Alberta is restricted to Calgary, so definitely some bright spots, good practices for us to be able to look into as well. It makes me also wonder about the patients the newborns that don't have a physician They're a little bit orphaned. I wonder if anyone can comment on that, both in terms of treatment and ability to safely discharge, what resources are available in the community for those patients.
Mona, if I could add to that one, as you know, the Ottawa Hospital had gone on to develop the Monarch Clinic, which are safe discharge or discharge-ready babies, and then the follow-up for their hyperbilirubinemia as well as the lactation support, which seems to have done a tremendous amount of job within the community. But I agree, the primary care is a very important challenges which we are facing across the country. But we do have that, and I believe MOFO has their own clinic in terms of looking after someone or bringing those babies, as well as the Queensway Carleton brings their own babies because they don't have immediate access to some of those primary care issues.
Okay, great. Thank you, Pradeep. And it looks like Dr. Zwicker has her hand up. Maybe he's going to add to this discussion. Go ahead, Kelly.
Yes, I would just echo, thank you for the wonderful update, and you have saved a lot of time in the community because you summarized these guidelines and now I don't have to read the document, so thank you. I would echo Dr. Merchant's comments that there is a program at the Queensway, it's a jaundice clinic. We've had to increase our mandate a bit to do well baby checks as much as we can handle because of the lack of primary care, and so that wraps into our jaundice management, and the MOFOR has their own jaundice clinic as well. So even though those babies from these two community hospitals don't go through Monarch, the hospitals have their own jaundice programs there. But I echo the comments about lack of primary care for any ongoing issues outside of jaundice.
Okay, thank you so much, Kelly. Thanks for adding that, and for all that you're doing to help really bolster services through the community as well. It's a major help to us within the walls of CHEO, and also for the patients and families. Any other questions or comments? There's lots of kudos in the chat to our presenters for a great presentation, and much thanks for summarizing that huge document. Maybe you're going to do the same for the CPS statement when it comes out. Won't hold you to that, but that would be nice. Okay, well, I guess with that, you've left us lots of time for great discussion. Thank you so much for a wonderful presentation, very helpful, and for any follow through that you might be doing to make sure that the essence of what you've distilled from these new guidelines can be made accessible to us when we need them at the point of care. So thank you again, and wishing a wonderful day to all. Thanks for joining.
Thank you so much, everyone. I'll send the slides to Dr. Odsent and have it shared with everyone else.
Great.
Great day.